the organizing committee for allowing me to share our experience in the Philippines. So I'm going to give you, they requested me to give an overview of the program in the Philippines and in the process, share with you how did we integrate the hemoglobinopathy screening within our national program. And then I will give you our data so far, and then share with you the challenges and our plans. Um, just like any other program, there are many challenges, but we decided to take them on, and we hope that we can continue improving our system. So just I see the audience, and most of us are neighbors, but to see where we are. We're in Asia Pacific region. We're an archipelago of 7,600 islands. There are three major groups. Politically, there are 17 regions, and this is followed by the health program, with the Ministry of Health. We're considered a low and middle income country. We have a population of 110 million. Infant mortality rate is still 22 per 1,000 live births. Our maternal mortality is still high at 64, and we now have 1.4 million babies births every year. 10 years ago, we had 2 million, so we have been slowly bringing down this number. So uh, just imagine the Philippines now with a lot of islands and a lot of water, and maybe the challenge of how are we going to introduce the program, the newborn screening program. So we started in 1996. We all know that newborn screening started in the 60s, mid 60s in the US. And uh, but it took us really a couple of decades before we were able to do our pilot. The first pilot really was in 1996 in 24 hospitals just in Manila. And what has happened with this pilot project has really become now a national program. So right now, each of the hospitals and each of the birthing centers, each of them will be implementing the program. So we basically collect by heel prick, and then they are sent to the lab. Now, so by what have we done as a strategy? We have divided the country by area. So a hospital or a birthing center gets assigned to one of these labs. As of now, we have 7 across the country. And you can see the number of samples that they run per lab. We call it a newborn screening center, which takes care of screening and then completing the diagnosis and the short-term follow-up, just like in any other program. The NIH is in Manila and runs close to 300,000 samples. The other big unit now is the one in Mindanao, down south. They run 308,000 samples every year. So the a hospital or a birthing center has no choice. Once they register that they want to offer newborn screening, they get assigned to one of these. So in the system, so we're now screening for 29 conditions. As soon as the diagnosis was made at the level of the lab, that's a newborn screening center, they get referred to a newborn screening continuity clinic and for continuing care. So it has been the commitment of the program that beyond the diagnosis at the lab, we have the clinics to take care of the follow-up with the specialist, which is either a face-to-face or teleconsultation. Even before COVID, we already had to implement teleconsultation because of the lack of specialists across the country. They monitor compliance to medical and dietary treatment. They actually facilitate the order and delivery of the medical food down to the homes of our patients. And interestingly, if the patient cannot afford to go to a clinic, then the Department of Health comes in because they facilitate the transportation of the patient. And they also take care of admission if necessary. Well, we have a big project right now on outcomes, just like any other program. We want to make sure that we're getting the right information from the patient so that we can defend its funding from government. So The program started in 1996, but we only started the continuity clinics in 2014 because we realized that it was not enough that we will send the patient to a private or a government physician. We wanted to put the structure. So right now we have 33 across the country, and this is manned by a part-time pediatrician and a full-time nurse, and they work with the endocrinologist, the hematologist, the geneticist, and so on. We have a scarcity of specialists. We only have 17 clinical geneticists across the country. We have only 12 genetic counselors in the country, but we're graduating another 18. Hematologists, we only have 83 pediatric. And for endocrinology, uh, we have more than 20 right now. So it is very important for us to establish the system for follow-up after the care. So this, in effect, tells you the story of the whole program. And let me just walk you through this because it is interesting exactly when we started to put in hemoglobinopathy. So from day one, we've been doing the heel prick. We had the option of cord blood versus heel prick, but we opted for the heel prick because on day one of the program, we already had plans of expansion to metabolics. So we did a pilot in 1996, um, and you can see I'll give it the story until the 2024. So let me just group my story. So first, we did the pilot in 1996 on 5 conditions, and you can see here that we have moved forward. So we added actually G6PD in the year 2000, despite the fact that we wanted to do expanded screening from day one. We actually were able to do this only in 2014. And you can see there that we have added the hemoglobinopathy as part of the panel for expansion. So there is a committee that reviews on when to add, what to add, and of course the funding goes with it. In terms of the laboratories, we have a formula. So you cannot just open a lab. We have a formula to make sure that we're able to bring down the cost. The regionalization of the laboratory is actually a strategy to bring down the cost of screening. So we now have 7, and by 2024, we're opening another 2 labs in the country. But I think that's going to be the end of the story in terms of laboratories in the country. In terms of finance and legislation, one thing that happened in the Philippines was that when there was great difficulty in implementing it on a national scale, we had to move to legislation. And you can see here that before we got the law passed, we had to work on the cost benefit, the value of screening, because we had to defend it in the legislative body. And finally, in this law, which I will show later, it was financed by 2006. It's covered by insurance. But looking at this slide, you can see that the law was passed in 2004. And as we were implementing this program, we realized that we had the rare diseases not covered in terms of comprehensive care. And that is the reason why we worked on another piece of legislation, which is the Rare Disease Act, which came out in 2016. And looking at this story, we had in 2006, we had coverage for 6 conditions. By 2019, social insurance covered the expanded newborn screening panel. Now, as we are working on testing, we have another group that's looking at the quality assurance of the whole program. We have several checklists to make sure that the labs, the clinics, the patients are actually following, coming up with the outcomes that we need. In terms of quality, realizing we don't have enough genetic counselors, we actually started a program, an MS in genetic counseling. As you can see here, as part of the long-term program too, in 2014, we decided that we had to set up the continuity clinics. And the last major step that we did was that in 2020, when we decided we had to open additional centers for human genetic services. You see, at the NIH, we have a comprehensive program for genetics led by the Institute of Human Genetics. It's one of the institutes of the National Institutes of Health. but the burden on the clinicians and the geneticists and other specialists was already too big, and we've opened up one in the Visayas and one in Mindanao. And this way, the patients on long-term care, short-term, long-term care, actually are handled by different groups of specialists. So as a whole, this is the story of our program, and you can see that each time we identify a problem, then we move on and look for opportunities to improve it, because it's not a perfect program, but we're moving forward. So I just want to mention a little about the law, because the law actually it's a simple law. If you look at the law, these are the major points. Number one, the Department of Health is the lead agency. Number two, it's covered by insurance. Number three, there's an office at the university that has become the technical partner of the program, which means this office was created specifically to help the Department of Health in the implementation of the program. The next bullet is an obligation to inform. In the United States, the law mandates the screening of the baby. But if you look at this one, we changed the wording. It's an obligation of the health workers to inform the parents of the value of screening. And the last point is, which I think was crucial for having the full implementation in all of the hospitals and in the birthing centers, is that it is a requirement for licensure and accreditation. So in other words, if a hospital or birthing center wants to operate, they will have to show a certificate that they are offering newborn screening. So let me give you now the story for the story of how we went about in doing this. As I said, we actually decided on expanding very early in the game. But how did we start? See, in the year 2010, we applied for a grant. The grant was quite substantial to come up with a pilot, but we actually were able to get some data from the California program, where there's a big Filipino population. And this one, just from 2005 to 2011, they had 111,000 newborns, and we were able to capture actually substantial numbers to be able to bring to the Department of Health. So we had these numbers, we have the data, and from there, that's how we moved on. We gave this information to the ministry, and that's how we were able to move on now. So just our argument with the government was that if with 111,000 newborns, we were getting this data, we projected a prevalence at that time and the possible number of cases if we were doing 100% of the newborns. That was basically the message we wanted to give the Ministry of Health. So finally, the advisory committee for newborn screening actually met and approved this. So within the structure of the law, there is an advisory committee dedicated to newborn screening, which is actually chaired by the minister or the Secretary of Health, and co-chaired by the executive director of the National Institutes of Health. In that committee, we have representation from the private sector, the academic, and the public sector. And in that meeting in 2012, the resolution was that it will be offered as an option for families, and that we should continue our discussions with insurance that they be funded. So this is now the master planning, which I'd like to share with you. There was another technical working group that was created, and we had to prepare a timeline. And looking back, it took us more than 2 years, actually, to prepare for expanded newborn screening. We had to prepare, we had to do the pilot, and then eventually we went national. So the first is the equipment. So there was a lot of, I'm talking about metabolic and all the other disorders, because you were jumping from 6 conditions to 28 conditions. So we had to look at the equipment, we had to upgrade, we had to make sure we had funding for it, and we had to make a choice for every test. So just working on the hemoglobinopathy, it was a debate whether it was going to be an IEF or HPLC, but because of the volume of samples that we had, we had to work on HPLC and work on CE for confirmatory testing. It was impossible to put molecular testing as part of our algorithm, but we were able to get a grant so that all the cases we were getting eventually had molecular testing because it was very important for us in terms of changing the algorithm and changing the cutoff and so many other things. So really at the beginning, there were only 5 labs that were doing this. This is happening simultaneously now because there's only one system across the country. So which means what's happening in one lab is happening to the other labs. And that's the kind of preparation that was really taking a lot of time. So as I said, the creation of the clinics were important because we wanted to make sure that this time we had specialists who will take on the patients who were picked up by the expanded newborn screening. As I said, we had to open a course. We don't have enough geneticists. And because we had to field, the plan is to have one genetic counselor for every province. We have 81 provinces, and we're far from that right now. So we're getting funding and scholarships for the students so that eventually all of them will be filled at the town. We had a massive campaign. We went to the broadsheets, we had brochures, we changed, expanded screening. We went out again on television. We have a big communications campaign actually, and that was happening for really more than about 2 years before we were even able to start. And we had to send people overseas and train. We partnered with David Millington of Duke University for the metabolics. We partnered with Dr. Carolyn Hoppy from the Binoff Children's Hospital, Oakland. So our technical people as well as hematologists went overseas, and then they had to come back and also train the rest of the people. There were a lot of meetings. We had to meet the hematologists, meet the pediatricians. We needed the buy-in because once we get a positive screen, somebody has to take over. So Carolyn Hoppy has the picture up there, and Dr. Thurwell from the Texas program a decade back actually helped us in organizing the expanded newborn screening. We had to work again on insurance because before we had expanded newborn screening, they were only paying for $12 for 6 conditions. And I just want to share with you that a newborn screening fee covers from education, the advocacy material, the poster, the brochures, the testing, the follow-up of the patients down the line. So we were aiming for $33 then for 28 conditions, but so far what we got an approval in May 2019 was $35 for 29 conditions. And it's a very tight budget, but it's a service and not a business. And so which means every time the value fluctuates, the dollar, goes haywire, then we also have a problem. But we cannot just change the fee. So it is the centers who will have to make the difference. So we cannot do this alone in the lab. So I just want to share with you that we have actually committees of panel of experts, and even during COVID, this photo was taken during COVID, they had to meet. The committees are in charge of the algorithms for screening, cut-off. Somebody's reviewed the data. Is the cut-off correct? Are we missing cases? Do we have too many false positives? We have to look at the protocol for confirmation. It's the same across the country. And we do have a frequently asked questions for doctors and patients. That's actually in our website. So as you can see here, we have a dedicated committee just for thalassemia. And they serve, and right now they're meeting monthly. In the past, they were meeting, I think, less frequently, but now in the past 2 years, they meet every month to review. There's enough to review actually on the committee level. So I just want to show you what has happened through the years. So I said the newborn screening started in 1996 really as research. We had a very small funding to be able to gather some information. The Department of Health actually came on board in 1998. The law was passed in 2004. But the message I'm sending here is that even if we had the law in 2004 and insurance coming on board in 2006, the coverage did not happen overnight. It took us a long time to get to where we are at about more than 90% coverage. So the green color represents the 6 conditions. The yellow one shows the expanded program. So you can see that when insurance was only covering the 6 conditions, that was the only one that was high. But in May of 2019, when insurance said we will cover expanded newborn screening, you can see that just really overnight, everything became yellow. I took note of COVID because when COVID happened, personally, I was worried that the program was going to suffer because we had 7,000 islands, the borders closed, water and land, and you cannot force the courier service to collect samples. The laboratories continued, that's one thing for sure. They had mechanisms of having 2 teams so that if one person got sick, there was another team that was going to take over. At the end of 2020, I had to give a talk on how we coped through COVID. And I must tell you, I was so surprised because this is what the people on the ground did. So imagine that every day, as a routine, a courier service picks up the sample from the hospital birthing center and it gets delivered to the lab the following day. At the time of COVID, the people on the ground, together with the Ministry of Health, changed their strategy. They used the military, the firemen, the police, and even the Navy to transport the samples across the border. And that is the reason why at COVID time, we only had the dip of 12%. But as you can see that we have, even during COVID, we have gone up and the coverage right now is 93%. This is where I say that it's important that people on the ground believes in it and accepts it because when the problems happen, then they will come up with their own solutions. So this is the result that we've had so far up to 2022. We're not ready to give all the information, but I think in a subsequent meeting, my teams will be presenting the data. And we've been cleaning up the data for the past couple of weeks now in preparation for this talk. And we think that there's really so much we can share as far as screening for hemoglobinopathy for those who are interested, consider it in their panel. So what were their challenges? Well, we had patients lost to follow-up. Okay, and when a baby is normal, and they don't think there's a value for a follow-up, for a confirmation, that was one of our problems. We do have some families who have refused confirmation. This also happens for the metabolic cases. So we do still have a percentage, and this is one part that we're trying to solve so that everybody goes all the way to confirmatory testing. The second bullet talks about just exactly what do we want to report, because we're really here to present the clinically significant disorders. When I talk to a pool of to hematologists, they also want to get the traits. So we do have the data for the traits, and we're now at the stage of deciding on how to handle it in terms of bringing down the information. And I know that in the US, they release the traits, but you need an army of people to be able to explain it now to the patients. The challenge is it's a continuing review for algorithm, and it's the same for all of the conditions. So just imagine all of the committees reviewing the algorithm and deciding on how they will move forward. This is an appreciation that newborn screening is really not static. It's only the logistics that probably will stay the same. But in terms of interpretation, it's really a very dynamic exercise. When new tests come in, new machines come in, questionable cases, do we miss a case? Do we have too many false positives? That's going to be the problem. So we're now at the stage of deciding exactly which ones we want to go to molecular. And this is going to be a big change probably by the end of the year. So what are we planning? We're reviewing algorithms for, for the disposition of cases. There has to be an exercise for closing cases, and teams will have to sit down. And this is not only for hemoglobinopathy. When it comes to, and I'm talking about congenital hypothyroidism and congenital adrenal hyperplasia, the endocrinologists have to sit down and help the program close the cases. Because sometimes the pediatricians at the ground or the people in the lab could not close the cases. So they actually have to come up with an expert panel to decide how to proceed. The second bullet talks about our algorithm again. We're doing a pilot of doing CE as a second tier, and then just moving to molecular testing for confirmation. Because right now, we have to look at the finances of this. Every time we have a step, how much is it? How much will it cost the program? The third bullet is really confirmatory awareness. We have to we really have an awareness campaign not only for the patients but even for the hematologists and the pediatricians, because getting a result is just one, and then of course you have to make sure that the patient is cared for after that. And we are working on collaborations, and as a matter of fact, I'll be collaborating with somebody from the region to help us probably resolve some of our questions within our system. So I've given you an overview of the program and how we were able to integrate, expand to the expanded newborn screening panel. I think we're there. We're not adding any more conditions, but maybe I'll give you a peek on what can happen 5 years from now. We are now putting together the data for SCID and SMA. Maybe these are two conditions that we probably will add in the years to come. So my advice to all clinicians who want to add a condition in our panel, they have to start doing their pilot studies. They have to work on the cases so that when the time comes that we can afford to expand, they can do it. But the hemoglobinopathy screening will probably be here to stay, and we will just be looking on how we can improve our screening, our diagnosis, our confirmation, and then follow up. And then we will just have to continue addressing the challenges that we have. So with that, I'd like to thank everybody for listening to me, and these are the people who made this happen. Thank you.